This is another episode of the Blossom Podcast, your number one source for everything bariatric surgery, from pre-op to post-op. Registered dietitian Alex Conception gives you real, raw tips and motivation through your journey. This is the Blossom Podcast.
All right, welcome back to the Blossom Podcast. I'm your host, Alex Conception, registered dietitian, and of course, with the better voice and the very beautiful Catherine Call. What's going on?
We made it. We're here again.
Aha, yes.
I'm so excited.
We have a very special guest today. It's been long overdue. Many of you want to know the man, the myth, the legend, and what makes this man tick. We got Dr. Apel in the house.
Boom, there it is.
So excited. So we see this guy, we hear this guy, we see him all over our YouTube, but we have not yet had a chance to sit down and have a conversation on a podcast. We got a ton of stuff to go over.
a lot of questions, and yeah, we'll dive deep into a lot of things. Of course, we'll go a little bit personal, but also the questions that you guys have in terms of bariatric surgery, some of those frequently asked questions, and we're going to hear it from the doctor himself.
I love it. Let's start it off. I want to know just a little bit about your education, your residency, your fellowship, and what kind of brought you to the specialty of bariatrics.
Absolutely. So I did all my training down in Tucson, Arizona. Residency 5 years, fellowship training another year after that. I came up to Vegas in 2016 to join Blossom. And again, I knew that I wanted to go into bariatric surgery about midway through my training, because as you do more and more different surgical subspecialties, you kind of learn what you like and what you don't like. And I like coming to work and having it be a happy environment where people are excited to be there. People are excited to have surgery. I like it where not only are you affecting someone's health, but you're affecting someone's mental health, physical health, their overall well-being. And there's very few surgical subspecialties that kind of check off all those boxes. Surgical oncology, even when you do your best work, sometimes the cancer wins.
Wow.
And again, that's fairly depressing, and that's not the kind of environment I wanted to practice in. As a plastic surgeon, yes, you're helping someone, but is it necessarily helping their global physical health? Maybe, but oftentimes not so much. It's more aesthetic. And so for me, this kind of knocks out the aesthetic portion. This knocks out the mental health portion. This knocks out the physical health portion. You're helping the individual. You're helping that individual's family. You're helping that individual's community. So it's like a win-win-win-win-win with very little downside.
True.
So for me, this is just, a great practice and a great subspecialty to be in, because everyone's happy to be here. Patients are excited to be here. Patients are thrilled and ready to have surgery. And there's very few other surgical interventions where people are happy to be there. You need your gallbladder out. You're like, oh man, I got to get my gallbladder out. This sucks. I don't want to have surgery. There's people wanting to be here. People are happy to be here. People fly from other countries to be here. So I'm happy to be part of that process.
Amazing.
That's actually how my rationale, my thinking in terms of working at a hospital versus private practice or bariatric surgeries, because everybody that I spoke to at the hospital didn't want to be there.
Correct, exactly.
Right? And are they actually going to change 20, 30 minutes of talking from newly onset diabetic or somebody who just had a heart attack, and after they talk to me, they're probably still going to go to KFC, McDonald's right after.
Or just want to get out of there. They're focused on moving on and getting discharged. They don't want to talk about the nutrition aspect.
Correct.
What was a close second on choosing your path?
Good question.
It was going to be plastics. It was number 2.
Interesting.
Yep.
Wow.
Yep.
Did you have any experience in terms of crazy stories?
Of course. Again, there's a lot of crazy stuff, but if I told you, I'd have to kill you.
Oh, okay.
There you go.
This is where life ends. This podcast.
Exactly, yes.
Sake of the entertainment for our audience. There we go. Interesting. So tell us, so you've been here with us since 2016. I cannot believe that. That time just flies.
I know.
What led you here to Blossom? And obviously, coming out of fellowship, I'm sure you had multiple other opportunities and options, but what made you decide Blossom? How'd you land here?
Again, after speaking with Tom Umbach, he had a great vision in terms of how he wanted things to unfold as the future came about. And so between us doing things cutting edge here, us, really patient focused, and us, kind of being able to tailor our program to the patients, it's kind of, again, a win-win-win situation. And for me, this is a very unique program, and I've been part of being able to make it even more unique since I've been here.
Absolutely.
So things looked promising when I joined, and things have certainly come to fruition and continue to be promising since I've been here, and hopefully will continue to be so as the years go by.
Absolutely.
You're a big part of that positivity and everything. When you say having the patient happy in pretty much every aspect, I've rarely seen you in a bad mood.
Damn straight.
And that's good. And I
Yes,
love
exactly.
That.
Correct.
I love that about you, and we get that from the patients as well.
Yeah.
And all the positivity, which is fantastic.
Yeah, no, again, it's easy to come to work when you don't really consider it to be work.
Yes.
Just coming to work and hanging out and having a good time and doing stuff that comes easy to you.
Yeah, chatting with people from all over the country.
Yeah.
We'll get back into that a little bit about the difference between how we do things and other practices, but I want to know, so we see Dr. Apel all the time. We see him in and out of clinic, in and out of the OR, talking to patients. What do you do when you're outside of work, though? Tell us about that.
Absolutely. So, as you can imagine, I got my wife at home, Christine, the 2 kids, the 2 dogs. So, when I'm working, obviously I go home, I have dinner, Christine and I hang out, we'll run some errands, we'll watch some TV. Things are pretty low key when I'm working. When I'm not working, we try to get out of town, check out different things in terms of traveling. My son's into volleyball, so a lot of my time recently has been kind of dedicated to that. My daughter, as Alex knows, has been into these beauty pageants, so a lot of my time gets sucked into that.
Yeah.
So there's
Dad life.
Between
Dad life.
So
Beautiful
between
family.
work and the dad life, there's not a lot of time left for me. But again, that's kind of what I signed up for, so I'm all good.
Yeah, you guys like to treat yourself to nice meals. I'm always saying.
Oh yes.
Give me your number 1 and or number 2, if there's a close number 1, best restaurant in Vegas.
Well, again, it just really boils down to if you want to go on strip or off strip.
On strip. Hit me on strip.
On strip, I like if you want like a nice, fancy, romantic type dinner, there's this place, Joël Robuchon.
Sure.
There used to be this place called Twist, but they closed down, so I don't know what they're going to open back up at the Mandarin. Off strip, I like Sparrow and Wolf a lot.
Love
I like
that restaurant.
anything on Spring Mountain. Again, you can get a lot of variety on Spring Mountain. For sushi, I love Sushi Hero on Eastern. Go there all the time.
Interesting. That's in my hood. I like that.
It's amazing.
Sushi.
And again, I just like trying out new stuff. I'll try anything once.
Yeah.
Even if it's horrible, hey, you live and you learn.
There you
but
go.
if it's good, you go back.
I love that.
What do you do to stay in shape?
First and foremost, obviously, eat well. Hello.
There you go.
And then, we try to get out. We try to exercise. Some weeks allow more exercise than others. But for the most part, again, just like we tell the patients, 80% plus of one's success is diet. So I got to follow those rules and eat well and live by what you talk.
There you go.
Yes.
Exactly. And you look great, by the way. So
Thank you very much.
Watching, you're hearing it.
Yes, exactly.
I love that. Well, good. So do tell us a little bit about, let's get into the difference between what we have going on here at Blossom and what we do, and really from your perspective, from a surgeon's perspective, because obviously in a traditional bariatric setting, you would be doing much more consults working up to the actual surgery. And same with you, Alex, would be doing a lot more of these visits where, you're
6
doing
months.
six
months
prior
or
to
longer
surgery.
even.
or longer.
I once had someone way back in the day have to do a monthly visit for 12 months.
Wow.
And something happened and he screwed up his 11th month visit. And the insurance company came back and said, hey, got to start over.
Oh,
So needless to
Painful.
say, he decided to stop. And I would have done the same thing.
yeah.
Because again, it's so archaic. There's no evidence-based medicine out there that supports all of these supervised weight loss visits before surgery have any bearing on one's success postoperatively. These are just impediments put in place by the insurance companies to get people not to have it so they don't have to pay for it.
Interesting.
Okay?
Yeah, and it makes sense too, because you're talking about somebody who needs help.
Yes.
And then you're going to give them all this criteria to do it in 6 months to a year.
Correct.
And if you follow it 100%, do you even need the surgery? You
Right.
know? And I want to say a large percentage of them cannot.
Correct, of course.
You know?
And again, by definition, the bulk of the patients that we operate on, they are starting off behind the 8 ball because they've got more hunger than others. They've got some genetic predisposition that has them have a tendency towards weight gain. A lot of these patients, I'll get in there and they'll just have the biggest gastric, like an impressively large gastric volume. And I'm thinking to myself, with a stomach like that, and you've got to eat until you're full to be satiated, their choices are either they're hungry all the time and their stomach's empty, or they eat until they're full, and even if they're eating well, they're getting more calories than they need,
Right.
and they're left with a situation where they're either hungry or they're gaining weight. And being in one of two situations sucks.
Yeah.
So for me, the game changer in the leveling the playing field is making your stomach smaller. And then once the stomach's smaller and more reasonable, and it doesn't take so much to feel full, then people do what they've always done. A lot of these patients, they don't come in having the worst habits ever. They come in with pretty decent habits to begin with, but they come in with a large gastric volume, and they come in with a genetic predisposition towards weight gain and towards some different hormonal problems, and have a low metabolic rate. And with those things combined results in them gaining weight. So all they need is a smaller stomach. And again, it's a straightforward, simple procedure. Our success rates are incredibly high. And so all these impediments that you find in normal programs, 3 months, 6 months, 12 months, meeting this criteria, meeting that criteria, jumping through all these hoops, they are put in place not to help the patient. They're put in place to prevent the insurance company from having to pay for things.
Right.
And then once a lot of the patients that we see here, they go through all the hoops, and then still the insurance company finds a reason to cancel it.
I was just going to say, we've had
it happens on a weekly basis.
Yeah.
So many patients.
So disheartening. So they've done all of this workup and have their mindset, and they have this whole list of things to do. They've done them all, and then it's like, well.
Correct, exactly. So for me, the bottom line here is this program allows you to, for the reasonable average individual like we see, follow some instructions, get the surgery, go home, get back to life, follow the rules, lose the weight, keep it off. I mean, again, it's that simple. This doesn't have to be a 6 to 12 month process. We've been able to condense in a very safe fashion the process down to, 4 or 5 days. You basically come through, you get all the work up here, we check out your heart, we check out your lungs, we check out your blood work, we make sure that everything's fine, we do the endoscopy, everything is done, but instead of it taking 6+ months, it takes 4 days. And then instead of you running around, canceling appointments, canceling work, having a whole bunch of disruptions in your life to get to the final goal, instead, you come out here, you have 4 or 5 days of disruption from your life, and you're back to normal life thereafter. And again, that's the whole idea here. We want to help people, but we want to do so without it being cumbersome on their life, without it being too annoying for their family, too annoying for work, too annoying for whatever they've got going on. Blossom is the place to be, where you take a tiny little pause from your life, and 4 or 5 days later, you're back on the road to health. You're back on the road to a much lower, healthier, happier you.
I love that.
As long as you make the right food choices.
Damn straight. Again, the caveat is follow the instructions.
Yes.
Yes.
Exactly.
Yes, exactly. Nice.
Touch on a little bit of who is a candidate for a program and who is not, because I'm very involved in the Facebook groups, and I see kind of what's out there, the narrative of our program and the nature of it. Mm-hmm. And it is disheartening for us and the patient too, when they make that phone call, they attempt to qualify, and there's a reason they can't move forward with us. And I would say almost 100% of the time it's because it's more safe for them to go inpatient.
Yeah, of course.
Talk a little bit about that, and in this scenario of the top reasons you see that you believe from a surgeon perspective, these people are better suited for an inpatient procedure.
Yeah, okay. So don't get me wrong. There are a lot of patients in America / the world that would benefit from bariatric surgery, okay? But we have to be careful about who we want to travel from out of state or out of country to come here, with the intention being, you come here, you get your surgery, you go home, you get back to normal life, okay? There are people where the weight has taken a permanent toll on the body, and the risk of an issue is much higher, and therefore I don't want to have you stuck in Las Vegas with a complication because it was something that could not be avoidable. If something cannot be avoidable, it's better to be unavoidable at home, in the hospital, near your family and near your support structure, than it is for something unavoidable to happen here when no one's around. So the key here is, if your kidneys have taken a hit, if your lungs have taken a hit, if your heart's taken a hit, if you've got permanent deficits from a stroke, if there's something that is too high risk to undergo either surgery out of town or surgery as an outpatient, unfortunately, you're not a candidate for this program. We have to be careful. The ideal candidate here is you're generally healthy with the exception of the weight. You've got the standard early stage diabetes, hypertension, cholesterol problems, sleep apnea, and so forth, but it's not limiting your ability to live your daily life. And then you come out, you get your surgery, you go home, life is good. We want to make sure that the people on paper that are higher risk, yes, we wholeheartedly support them getting surgery, but if they're higher risk, we can't have them come here and have a problem and then not make it home, okay? And again, it's not that the risk of morbidity or mortality is prohibitively high in those patients. It's just better served at home under a little bit more of a controlled, monitored environment in the hospital.
And it's
that's
good
just the bottom line.
Mentally as well for those patients to heal better.
Of course.
As well too. And we've sent some patients home because after testing
Yes.
it was very high risk and get these things under control, and they've come back as
Correct.
well.
Right.
And they've actually been very grateful for that. Of course, it's
again,
gonna
we got to do
be-
things safely here.
Right.
Again, safety is the number one priority. We got to focus on the patients. I hate canceling someone because their blood pressure is uncontrolled. I hate canceling someone because their blood sugars are out of control. But the bottom line here is it's irrefutable that going to surgery under circumstances like that is not ideal. We only go to surgery under the most ideal circumstances.
Yeah.
Everything's optimized. Blood sugar's optimized. Blood pressure's optimized. Weight loss, pre-op weight loss has been optimized. They're not smoking. They're off immunosuppressants. Again, we want everything on paper to look as perfectly as is possible, and then we just proceed with surgery and hope for the best.
Right.
And when we do that, our outcomes are tremendously successful. Our complication rates are tremendously low. But without adhering to those strict criteria, and if we were to cut corners, then we would be sacrificing safety at the patient's expense. And again, it's just not worth it. I'd rather have you be pissed off at me because you flew here from Oklahoma and we canceled you, rather than you flew here from Oklahoma, I didn't cancel you, I did the surgery, I cut some corners, shit hit the fan, and now we're dealing with someone in the hospital for 2-3 weeks post-operatively here in Vegas, and they're like, oh man, I wish you wouldn't have done the surgery. Well, shit, yeah, I agree. I wish I wouldn't have done the surgery either, which is why I don't do the surgery unless things are as perfect as they can be.
Yeah. And I will say it's very uncommon for us to cancel while you're here.
Correct.
But you just mentioned a few of those scenarios where
Testing.
the testing, yeah, and it's part of the qualification process. It's so important that we ask about your primary care, ask about what specialists you see, because if you don't have established care with a primary care, that's a problem. We need to have those, we need to make sure that your blood pressure is under control and so forth. And that kind of brings up a question about the primary care. What do you feel like our patients' primary care physician's role that they have in the surgery, both beforehand and then afterwards, throughout the rest of their partnership as patient and physician? What is that role?
So again, for me, preoperatively, I want to make sure that there's no unknown factors. I want to make sure that you don't have high blood pressure that you're unaware of. I want to make sure you don't have diabetes you're unaware of. And if you do have those things, it's better to make yourself aware of them, get treatment if necessary, get things optimized and fine-tuned before you come out here. So the goal of the primary care before surgery is diagnose any unknown disease, treat any existing or unknown disease, and get patients optimized for surgery. Okay? The most common scenario where someone gets canceled is they think they're otherwise healthy, they feel great, they come out here, and they're caught off guard by the fact that their blood pressure's 210 over 120.
Which could have been avoided by a visit to a primary.
So even though you feel fine and you don't feel like you need the primary care, a quick little checkup is cheaper and less time consuming than flying out here to be canceled a day or two into the process. So yes, I fully admit that a lot of, especially younger patients, if you're in your 20s, early 30s, and you're otherwise healthy to the best of your knowledge, even a quick little visit to a primary care before you get out here is recommended, because then you won't be that weird random patient that doesn't realize they have high blood pressure, doesn't realize that their A1C is 12 and their blood sugar is 390. Okay, there's almost no way if you see your primary care within 6 months and you get out here that something's going to be weird or unusual or unexpected or have kind of declined to the point where you knew you had high blood pressure, it wasn't being treated, and then all of a sudden it's so much worse 4 months after you've seen your primary care. It's just unheard of. So it's not impossible, it's just really, really rare. So for me, knowing that you're truly healthy and not just feeling healthy before you get out here is important, and that's where the primary care comes into play. And then post-operatively, again, there's a lot of patients on medications that need to be adjusted or eliminated. There's a lot of patients that need the occasional check-in when it comes to post-op labs at 6 months and 12 months. So the role of the primary care hopefully is limited post-operatively because they're getting healthier. They need less medications. They need less time at the primary care's office. But the key here is if you're plugged in with the primary care before surgery, you follow up with them after surgery, and then just once a year you check in with your primary care, make sure nothing's new, nothing's unexpected. Again, you have doctors available to you, I recommend keeping that in mind and using them to your advantage post-operatively, because oftentimes the stuff that can really alter the course of your life can be discovered much sooner in the time frame if you see a doctor on a fairly regular basis.
Right.
I don't need to see a doctor twice a year, once every couple of years, something like that, especially if you're in your 20s or 30s, and then yearly thereafter is certainly the recommendation to make sure there's nothing going on that you're unaware of and that you want to catch before it becomes serious.
And I'd like to add, those numbers don't change within that short amount of time, like significantly. Too,
Correct.
I can't tell you how many patients that I see are hearing from me for the first time that they are pre-diabetic or diabetic.
Yes.
And those who are on medication, it can be very high risk if you don't talk to your prescribing physician or if you're primary care, because you may be off medication literally days after.
Correct.
Or a week after, because now you run the risk of too low blood sugar.
Correct.
Or too low blood pressure, things like that.
Correct. I mean, we see it all the time. People get the surgery and they've been taking insulin for 20 years, and within days of the surgery, their insulin requirements are cut in half / removed. I've seen plenty of people with such terrible diabetes that they're literally getting the surgery for the sole purpose of curing their diabetes, and within days, insulin requirements are gone.
Wow.
Not only that, just a pre-op diet.
Correct.
You know, it's like,
absolutely.
oh, wow, holy crap, I haven't seen those numbers in years.
Correct. And that's also why it's important that the primary care or the endocrinologist is involved, because if you're doing the pre-op diet well, by definition, you're getting much lower carbs and sugars in than you're used to, and so the blood sugars should respond accordingly. And if you're used to taking a whole bunch of insulin and pills for your diabetes, and you start the pre-op diet and you don't make some adjustments accordingly, you'll find yourself with your blood sugar too low even before you get out here, because you're following the diet like it should be, but you're still treating with medications as though you weren't on the pre-op diet, and that is where things can get a little risky. So it's always important to make sure the primary care or the endocrinologist is on board so that they know to make some adjustments and tell you what to cut out, how to do things, sliding scale, whatever it is, both pre-op on the diet as well as once you get here and once you get the surgery.
What would you say to a patient who's considering weight loss surgery, has a couple specialists and sees a PCP, but maybe one or both of those doctors aren't on board? What would you say then?
You know, again, for me, the key here is this. The data is irrefutable. I mean, there's not a bit of evidence-based medicine out there that does not support bariatric surgery as the only effective tool for meaningful weight loss and as a surgical tool for correction of type 2 diabetes and so forth, okay? If primary cares aren't on board, it's often because they aren't as knowledgeable about the topic and about the science as I am. I mean, again, any doctor wants to be helpful. They went into this field to help people. And so there's often a bias or a stigma, even on the doctor's perspective when it comes to these surgeries, but it's often because they don't realize that it works, and they don't realize that very little other options work as effectively. I mean, again, medications don't work, diet doesn't work, exercise doesn't work. Yeah, that stuff helps if you're 10 pounds overweight. But once you've gotten 50 plus pounds overweight, the traditional interventions that a primary care would recommend just don't cut it. And then the other thing here is, of course, once you become a lot healthier and once you don't need medications for diabetes and hypertension and so forth, and once you don't need to see these providers as often, I wonder truly if there's a bit of a concern, hey, if this person gets the surgery, are they going to need me anymore?
Interesting.
And, again, I can't say with certainty that's the case. I hope it's not. But these are things that run through my head because, again, the data is irrefutable. It's like saying, oh, someone had a heart attack and there's certain medications they should be on. It'd be like a primary care questioning those medications. No, the data's out there. The research is out there. It's evidence-based medicine. Bariatric surgery works. Bariatric surgery is the only effective tool for meaningful weight loss in patients that have such an excessive amount of excess weight. But for primary cares to kind of frown upon it or dissuade them, either they themselves have had a bad experience or they don't realize that our program provides the support that it needs to be successful. They, see someone who's gone to Mexico, gotten the surgery, has no support, makes no changes, and then the primary care is like, oh, the surgery doesn't work. Well, it's not the surgery, it's how you use it. And we teach you how to use it well. And so, again, it's irrefutable that the surgery works, and more primary cares, especially younger primary cares that have done training more recently, are on board with it. And as the primary cares who were in their 60s and 70s who weren't really on board with bariatric surgery start to retire, hopefully the overall population of primary care and endocrinologists that are in favor of the surgery starts to grow. Because again, the data's out there, guys. It works. It works when you use it well, and it works when you use the tool as it should be used.
And the sleeve is also fairly new. It's on the newer side of bariatric surgery
Correct.
as well. So a lot of the data and a lot of the bias would come from the bypass, Roux-en-Y, things like that as well.
Correct.
With that being said, I guess that can just carry over into the bias and with the healthcare professionals. And,
absolutely.
I don't think that's a good idea, et cetera, et cetera.
Correct.
Because of that old information.
And again, realize we get almost on a weekly basis a doctor as a patient.
Yes,
we get on a daily basis nurses, respiratory therapists,
PAs.
other hospital personnel on a daily basis.
Yeah, we do.
So again, clearly this stuff works, and it's just taking time for the general medical community to catch up with how well it works and how effective it is and how it's really the only other option. I mean, truly speaking, as some primary cares are hesitant, on the flip side, we're starting to relax the criteria for getting through the gates. You know, we're finding that patients with brittle type 2 diabetes with a BMI of 27 plus benefit from the surgery. You know, I've had insurance companies approve weight loss surgery for someone with a BMI of 27 with tough to control diabetes strictly for the diabetes. This is not only weight loss surgery, this is metabolic surgery.
Right.
So more and more we're starting to realize that metabolic surgery is something that can effectively change somebody's life. And even if you don't need this for pure weight loss, if you've got tough type 2 diabetes, you know, the surgery works. You do a sleeve, you do a bypass and something like that, they don't have diabetes anymore. And the sooner you intervene, the more likely it is to work, because, you know, if you've had diabetes for 20 years, yes, there are patients who get rid of it altogether, but if you've had diabetes for 2 years and they get the surgery, the likelihood of curing the diabetes is that much higher.
Speaking of metabolic surgery, let's talk about the set point. Did you want to
absolutely
explain the set point a little bit and how anybody who is just hearing this for the first time, how would you explain it?
Absolutely. So the metabolic set point is kind of like an evolutionary adaptation to survival. Okay, so you got to think about it this way. You know, hundreds of years ago, thousands of years ago, as human beings, you know, we would eat, but food was not as readily available. And it was more the hunter-gatherer type situation for most of human history. So we would eat, we'd kind of store calories away, and then when a period of starvation would hit, or there'd be a bad crop for, you know, in the spring, whatever it is, we would have extra calories available to us to survive a period of caloric restriction or caloric starvation. Okay? But what happens is, through evolution and through various genetic advantages, the body kind of got to say, hey, let me store some calories away. Let me set this as my set point such that when I take a hit, I don't take a hit that's critical. If you weigh 150 pounds and you lose 75, well, 75 pounds isn't compatible with life. So you're going to die if you lose 75 pounds and you start at 150. But if you're starting at 225 and you lose 75 pounds, you can get to 150 safely, and then your body wants to get back to 225. It thinks the weight you've lost represents a period of starvation from which it's got to recover. So the key here is, the only way to protect you from having your set point deviate is don't deviate it in the first place, which basically means you've got to have the foresight to not gain weight to begin with, which means you've got to have the foresight as a young adult to not make poor decisions and not do what people do when they're young adults and when they're teenagers. And on top of that, it also requires you not having a strong genetic predisposition. There are plenty of people out there with the genetics that just result in them eating or looking at anything, and the weight just piles on. And again, they're eating well, they're in a caloric restricted diet, they're exercising well, and still it's a hormonal component to the weight gain. So the key here is, with the metabolic set point, for the vast majority of the patients, if you weigh 250 pounds right now, if you go on a diet, or you start exercising, or you go on medications, or you get the lap band, or you get the gastric balloon, those are interventions that don't affect the set point. Your set point's still 250. You do whatever you do, you go on the medications, you lose 50 pounds, you're all happy, you're at 200 pounds, you're like, yes, I lost 50 pounds. Well, you can stay at 200 pounds if you stay in the medication. You can stay at 200 pounds if the balloon remains in place. You can stay at 200 pounds if the lap band doesn't fail you and you stay at 200 pounds with the band. The moment the band fails, they pull the balloon, you stop the medications, the set point kicks in, the body wants to get back to 250. The body thinks, hey, the 50 pounds I lost represents a period of starvation or caloric restriction that I've got to recover from. So when the next cold winter comes about, I'm back to 250 and I can handle another 50-pound weight loss. Okay? The problem is, without a major intervention like surgery, you cannot affect the set point. Remember, we had those people from The Biggest Loser. Case in point, they went on the show, they were in a very controlled, restrictive environment. Anyone can lose weight with that kind of caloric restriction, that kind of exercise and so forth. But the moment they're dropped back into regular life, slowly but surely the set point kicks in. The bodies try to get back to where they started. They get back to where they started and then some.
Right.
So the body thinks that as you gain weight, it's trying to keep that at its new set point to protect you from a period of starvation or restriction or whatever it may be. And it wants to change its set point only with surgery. And now the key here is, again, back to the 250-pound patient. You're at 250, you go on an aggressive diet, you get down to 200 pounds, okay? You could stay at 200 with a continuation of the aggressive diet, but who can diet forever? Who can exercise aggressively forever? Who can stay on these expensive weight loss medications forever? You can't keep the gastric balloon in forever. Oftentimes the lap band fails. So if you're doing something that isn't going to affect the set point, you got to do it forever. And every single day when I'm doing a consult, I have patients who are like, hey, I'm at 280 today. I lost 80 pounds last year, and now I'm back to 280. And it's because they can't diet forever. They can't exercise forever. They can't be that aggressive forever. When regular life kicks in, the set point kicks in, the weight comes back. The good news is we have an answer, which is a true surgery. The lap band doesn't count. The balloon doesn't count. You got to do something real. You got to do the sleeve, the bypass, or the duodenal switch. Those are events that reset the set point. So now back to the patient that weighs 250 pounds, you start at 250, you get the sleeve, you lose all this weight through the standard diet and exercise like you do with everything else. But when you end up at 160, 6, 8, 9 months later, well, guess what? That is where the set point starts to solidify. That's where, even with regular life coming back, the body is okay with staying there. It's not trying to get that 90 pounds back. It's okay with staying at the new set point. So for me, this metabolic and weight loss surgery component, again, all I really need it for is to reset the set point. If we had another means to reset the set point, you wouldn't need surgery. You could aggressively diet, take a pill, reset the set point there, and stay there comfortably with ease. But until we find the pathway or pathways that helps the set point reset, unfortunately, we're stuck with the aggressive means to get the weight off and keep it off. And for us, that's the surgery. So there, almost every single person that comes here has lost more weight in total over the course of their life than they currently weigh. If you've been dealing with obesity for 20 years and you've been dieting and exercise on and off for 20 years, you've lost more than 250 pounds if you add it up. True. And yet they come here and they're still 250. This is the final way to lose the weight, keep it off, without driving yourself nuts with constant dieting, constant exercising, constantly shelling out $1,000+ per month on weight loss medications. And again, that's what it comes to. If you want to make a final change, you want to quit the roller coaster, and you want to reset the set point, the surgery is what you got.
And there's evidence of this as well. Just reflect on your lifestyle in the past. You haven't dieted. When you haven't dieted, you can eat in surplus and then you will eat in a deficit, but for somehow you're kind of staying within this 5-10 pound range. Mm-hmm. And then of course you try to diet, then you can lose weight, but then all of a sudden we gain it back.
Yep.
And same thing with on the lower end. I just have like 10 pounds to lose, but something keeps bringing you back up to that weight that you kind of are comfortable at.
Correct.
Now this is not to say that you cannot do this. It is possible, but the caveat is there is a mental struggle. It is actually dieting, and if you don't enjoy this, it is not sustainable.
Yeah.
Correct.
It is not sustainable.
Correct.
And you didn't get to 250 pounds because you enjoy dieting.
Correct.
So.
Of course. And again, the bottom line here is, it's one thing. There are certain patients that can do a caloric restriction without being too hungry. But again, the bulk of the patients that I see, they've got impressively large gastric volumes, which means they have impressively large ghrelin release, which means they have impressively large hunger and appetite, which means they have impressively large volume requirements before they're full. And in those kind of patients, dieting is hard. I mean, it's hard to be hungry. There are certain things in life that are hard to fight. You can't hold your breath forever, okay? You can't abstain from sexual behavior forever. and you can't avoid eating forever. Certain things in life that protect our species and protect us from going extinct are breathing, reproducing, and eating. That ensures our species survival. And so when you're trying to fight the urge to eat, it's really, really, really tough. The sleeve kind of levels the playing field, so to say, because it removes a great deal of that drive to eat, which makes approaching food much easier. And of course, with the sleeve, not only are you reducing hunger and you're reducing ghrelin and you're reducing the drive, but you're also drastically reducing the volume. So even when you do eat, you can eat very little before you're incredibly full. So again, the key here with the sleeve, guys, is yes, you've got to eat well. You got to do low carb, low sugar, force the body into ketosis, or force the body as close to fat burning mode as you can. Once the weight's off, the set point's been reset, it's pretty easy to stay there. You just have to be reasonable. Most of us are reasonable to begin with. They just need something to help. And the key here is if you're eating well 4 or 5 days a week, even if you're not eating great the other 2 or 3, everything balances out. That's hard without the surgery because even if you're eating well, if you've got a low metabolism, if you've got some genetic predisposition, you could eat well every single day and you're still gaining weight. It's because you're eating more volume than the body needs, you're getting more calories than the body needs, and you're exceeding the caloric, your caloric requirements. If you need 1,200 calories a day and you got a normal stomach or you got a big gastric volume, it's hard to fill up on 1,200 calories a day.
Yes.
If you've got a big 60-ounce stomach, try being full on 60 ounces 3 times a day. It's impossible. Even if you eat lettuce and you're eating a head of lettuce 3 times a day, I mean, again, that's just water and, cellulose. But for me, the key here is it's really hard to be hungry, and feel full when you have a large gastric volume, you got a big appetite, and then you eat, and some people are hungry 2 hours later. And I've seen people, and again, I see stomachs all the time, and some of these specimens I pull out, it's on like a patient who's a female, 28 years old, 5'2", and they've got a stomach like you'd expect from a guy in the NFL. And it's no wonder they can't lose weight and keep it off because they're constantly hungry, and it's either they're starving themselves or they eat until they're full and they get more calories in than they need.
Interesting.
You can request actually to see your stomach if you wanted to.
Careful putting that out there, Dr.
Well, people love it. I love it too because I like to see. Again, that's the key. When you go, some of these people are just amazed. They literally have like a stomach, and once you fill it up, it's like a football.
Right.
And it's no wonder that they've struggled. But when you go from the football to a small banana, if that's the game changer. And that's where people are like, oh shit, I don't eat healthy. I don't eat unhealthy. Most people that are here don't eat unhealthy. They're not eating fast food 3 times a day. Mm-hmm. They're not eating nothing but junk 3 times a day. So
home cooked meals and everything.
They're doing what they should. They're eating well, but they just need more volume than the caloric requirements.
Yeah.
Yeah. And who wants to eat a head of lettuce? No.
Damn straight.
Not me.
I'll need like 4 sauces and make that palatable. So, in talking about obesity in general, specifically in the U.S., you kind of mentioned 2 factors, genetic disposition and kind of just American culture, yes?
Of course, environment.
Do you think that there's anything outside of those 2 things that lead people to have a BMI of 40, 50, upwards of 50?
Again, in my mind, the vast majority, everybody's seen My 600-Pound Life. Everybody's seen, those kind of shows. In my opinion, to get to a BMI that high, there is certainly a behavioral component. Those aren't the patients that are eating generally well. Nobody gets to 600 pounds or greater that eats generally well, is going to work, raising a family, having a normal American life. The vast majority of patients that we see here in this program, they're doing their best, but they just have the genetics against them. They have the large portions against them. They have the environment where everything involves with eating, everything involves with going out, being quick, getting it done. Again, processed food, getting things done quickly is not healthy. You go over to Europe and you order a dinner and the dinner comes out and you're like, shit, where's the rest of it?
Right.
Because the portions are so small, but that's just the way they eat.
Yeah.
So in Europe, the portions are much smaller and you walk everywhere. I mean, again, the cities are much more concentrated because they were developed before cars and, mass transit was available. So people walk everywhere and people use bikes and so forth. So there's a big difference between the way things are in, Eastern, Western Europe versus America. And it's because we've got everything so easy for us. We hop in the car, we go to work, we come home, we're busy, we're tired, it's been a long day, we have this work ethic that exceeds that of other countries. So by the time you've worked from 8 to 6, you're tired, you got to take care of the kids. So between being tired, between the environment, between the food and the quality of the food, again, a lot of the stuff we're exposed to, whether we realize it or not, it's working against us in terms of not putting weight on. Okay, so it goes back to the comparison in Europe. The ingredients in Europe and what they use to cook in Europe and the availability of certain foods that kind of pack on the pounds, it's far less. And then Europeans come out here and they put weight on. Or you grew up in Africa and you come out here and all of a sudden within 10 years of living in America, you're basically an American. You look like an American. You look like someone who's been living here their whole life.
It's so true. We had a company, two gentlemen journalists from Italy that came a couple years ago and wanted to do a piece on obesity in the U.S. And they had never been to Vegas before. Well, first they went to the Heart Attack Grill where you're over 350, you eat for free. Their mind was blown. And then I said, do you guys know what Costco is? Do you know what Walmart is? They had no idea what it was. And I said, I got to send you to Walmart. Because they're used to a bodega type situation, a tiny store, and that's a grocery store with fresh produce and meats to cook, and that's it. Like that. These guys, their minds were absolutely blown into pieces because, first of all, they're like, why is your chicken so big? And not only that, why are the portions so big? And why do I have so many options? And what is this frozen food aisle?
Correct.
Their minds were blown.
Correct. It's crazy. And again, the bottom line here is healthy food isn't cheap. And cheap food isn't good for you. And unfortunately, this day and age, you want to be full, you want to eat something and have your hunger satiated and go about your day. But once you eat food in America and you're full, you've consumed a lot of calories. You've consumed a huge portion because, again, people are taught not to waste. So they put this big plate of food in front of you and you're like, cool, let's eat it. And you do so, and you get many more calories than you need. And then you're not walking everywhere to get the caloric burning to compensate for the extra calories. So we're burning less calories than our European or Asian counterparts, and we're consuming far more. But that's why, and again, there's studies out there that prove it. I'm sure we all know someone that moved from another country, had that diet, had that lifestyle, and within 10 years of being here, now had the westernized, Americanized problems with their weight because they're eating like they're eating here, and they're not eating like they were at home, and they're not as active as they were at home. So
thanks to the pandemic, we're all working from home.
Of course.
In our own home office or
so mobility is even more limited, and you got DoorDash. You take, press 4 buttons on your phone, and you can get whatever you want right at your door.
Correct. Again, the deck is stacked against us when it comes to being healthy in America. And, there's a lot of financial and political motivations behind not letting things change and maintaining the status quo. Okay, everybody knows McDonald's and junk food isn't good for you, but the businesses are still thriving. It's like the go-to. McDonald's in America, it's like McDonald's Americana. And yet, we know for sure that it's just poisoning the public.
Wow.
But is McDonald's going to close? Are they going to say, hey, we realize that this stuff isn't so good for you? No. They spin it and say, well, in moderation, it's okay. With a healthy, well-balanced diet, it's okay. We tell you how many calories are in there. But it's like, hey, here's some cocaine. It's not good for you, but here, if you want it, you can have it. Well, some people are going to turn it down. Some people can't. Some people are going to get addicted. But if cocaine's not available, if we treat junk food and processed food and things that are slowly poisoning us like a drug, then it's a different story. But there's a difference between something killing you in the short term versus something that kills you over the course of a lifetime and shortens your life over the course of 30, 40, 50 years. And then, of course, the other flip side to this is there's a huge multi-trillion-dollar industry in terms of big pharma where having people not be so healthy helps. Like treating people with medications is something big pharma wants to continue. Mm-hmm. If everyone in America was healthy, all the pharmaceutical industry would go by the wayside.
It's true.
Okay, so again, it's hard to make big changes in America, especially when there's billions or trillions of net dollars at stake. But all we can do is affect patients on an individual basis. And the bottom line here is, here at Blossom, we provide the support structure, we provide the surgeries, we provide the post-op care necessary to fight all of the stuff that the deck has stacked against us thus far. And it's really the only thing that works.
Absolutely. That's good.
That's why I got into what I got into, is more preventative than anything. Right? It reminds me of Chris Rock's skit. He's like, "There's no cure. There's no money in the cure. It's in the medicine."
Correct. Exactly. Correct. That's the bottom line.
And you were talking about evolution and things like that with the metabolic set point. Well, I think the evolution is actually abundance is the evolution. You know, there's just so much of everything, and we want it quicker and quicker and
Correct.
quicker.
And more of it.
And people want more for their money. And unfortunately, what they're really asking for without realizing is, hey, I want a good value for my $5. So I want as much food as possible for $5. I don't want an appropriate amount of food, an appropriate amount of calories for $5. I want a lot for $5. And so we give it to them.
Yeah.
And then all of a sudden, they have a huge meal. You know, a burger, fries, a huge, Coke, and they got their five. Yeah, exactly. They got their $5 worth, and they're happy. But they've got their whole 24-hour caloric needs in that one meal. And then because it empties quickly, because it's basically carbs and empty calories, you're ready for dinner after lunch, and then you've doubled that. So people want quick convenience, and they want value for their money. But unfortunately, they don't realize that they're getting value, but they're getting value and poor health as a result.
Wow.
Exactly.
Insane.
And it shows in the labs.
Yeah.
Of course.
Right.
Patients, exactly.
So we talked a little bit about the metabolic set point and how it's only, actual bariatric surgery that could reset that. I kind of want to get into a little bit of the question.
Well, hold on. So bariatric surgery is the only thing that can reset it. A lot of things affect it.
Okay.
So menopause can affect the metabolic set point. Pregnancies can affect the metabolic set point. Certain major life events can affect it, but unfortunately it only affects it in terms of trending it up.
Right.
The only thing that we know that trends it down is the surgery.
Right.
Or if you have iron will.
Yes. But again, it's not necessarily iron will. You can fight the set point. Again, if you weigh 250 and you go on a diet and you get to 150, if you stick with the caloric restriction, you stick with a very specific diet, protein shake for breakfast, protein shake for lunch, tiny little 6-ounce portion, just like the pre-op diet. If you do that forever, you'll stay at 150, even though the set point's at 250. Your body can't get back to 250 if you don't give it the opportunity.
Yes.
But the key here is 99% of patients go from 250 to 150 through aggressive means that are not sustainable. And then once life gets back to normal, school's back in, they've got stress at work, they got stress at home, whatever it may be, they can't stick with 2 shakes a day and a small meal. They go back to, I'm hungry, I'm going to just have a breakfast sandwich. Then, there's a nursing, luncheon at work. So I'm going to have, everybody brings a little bit of something and then just go to town. You can't, the vast majority of people don't have the willpower to diet for their whole life. And part of enjoying life is obviously eating things you like and so forth. With the sleeve, after you've reset the set point, you can continue to do so. But if you're on a very, very strict diet and you're trying to lose weight and lose 100 pounds and keep it off through diet and exercise alone, you can't afford to enjoy much.
How long would you say it takes to reset that set point?
After surgery?
Yes.
Well, again, after surgery, the sooner you're at your goal, the better. And that means that the body has more time to solidify that new set point as the new set point. Mm-hmm. So for me, if wherever you're at by about 12 months, maybe in some individuals can squeak it out to 18, that's basically going to be where the set point kicks in. So for me, if you're starting off at 250 and 12 months into the process post-op, you're at 180, it's going to be easy to stay at 180. It's going to be a challenge to squeak much more meaningful weight loss out beyond that point. You might be able to get to 170 in the next 6 months and keep it right around there. But for the most part, you got to get to where you want to be as quickly as you can. And then the body solidifies that as the new set point. And then it's pretty easy to stay there. Yeah. You got to be unreasonable to have significant weight gain post-sleeve.
I mean, realistically, it's going to be a lot easier for the body to fight to get to 180 than 250, right?
Correct.
Because that's essentially what's happening. So you can diet down to 150, but the body's just trying to get to 180 versus trying to get to 250.
Correct.
And do you feel that the starting BMI, does that have a factor on how quickly one loses? Because you're talking about that honeymoon period is really 12 months, and you really want to maximize it by following the plans that we put forth for you that we know actually works. But do you see that somebody who, let's take again that, for example, the 250 pound patient, if somebody's starting at 250 versus either 350 or 180 and you're 5'2", what is the BMI factor, like a starting BMI factor? Do you find that people lose slower when they have a lower BMI?
Yes, unless the diet plan is tailored to the individual. Okay, so here's what it comes to. By definition, if you're starting at 350 and you're following plan A, then most patients should lose more per month at 350 than someone who's starting at 180 following plan A. But plan A might not affect the patient at 180 the same as it affects the patient at 250 the same as it affects the patient at 350 the same. So the key here is, yes, we give some general recommendations, and yes, we expect certain results based on those general recommendations. But for me, there's always some fine tuning that could be done. We start off saying, hey, 50 grams carbs a day should do the trick. And for the vast majority of patients, they'll get good, meaningful weight loss with that. But guess what? If you grind down and go to 40, you lose more. If you grind down and go to 30, you lose more. If you further restrict calories, you lose more because you need to tap into more of your stored fat reserves. So there's always the broad strokes that we give to everyone, and then the fine tuning that we should be doing on a monthly basis if you're not losing the bare minimum.
I'd like to add to that, and that is the unrecognized factor, and that is muscle mass.
Yes.
So muscle mass is huge, and you can beat the same BMI to patients, but with a different muscle mass, the one with greater muscle mass will lose more effectively and a lot more because there's a greater demand.
Correct.
So that's just something else that would actually contribute towards that BMI factor.
And that what we tell our patients is a minimum of roughly 10 pounds a month for the first 6 months. And if you're not reaching that, to be in touch with either the coordinator, call the office, figure out what we can do to try to get you there.
On that note, I do want to take a break. We've covered so much so far. We're here with Dr. Matt Apel, Catherine. We've discussed who's a candidate, the differences between Blossom and other programs, expectations, qualifications, what could go wrong. We also discussed the metabolic set point, so a lot to digest. But I hope you guys have enjoyed this conversation as much as I have so far. So stick around for part 2 of this interview where we cover a ton more. Until then, I will see you guys in the next. Peace.
This was another episode of the Blossom Podcast. For more motivation and future episodes with Alex, make sure to subscribe so you don't miss out on any life-changing moments.